for either staying or moving to the room. Like I said, we'll move on with our next presenters once these good folk have settled down. So yeah, Anne and Farah from Arden GEM are going to talk to you about early warning systems, and in particular in relation to hypertension. Okay, over to you. Thank you.
Thank you. My name is Farah Adam, and I am a data scientist working for Arden GEM CSU. And with my colleague Ante, we'll be talking to you about an early warning system to flag uncontrolled hypertension. So first, let's define what is hypertension. So hypertension is where a patient has a high blood pressure, and blood pressure is generally measured with systolic blood pressure and diastolic blood pressure. And the patient is diagnosed to have hypertension when their diastolic blood pressure is at or above 90 millimeters of mercury, and or the systolic blood pressure is at or above 140 millimeters of mercury. And then when a patient has hypertension, they are considered to have uncontrolled hypertension when their blood pressure remains at hypertension level whilst they are taking blood pressure medications. And for UK statistic from NHS England, we have some statistic from 2022 where 30% of the UK population has hypertension and 50% have uncontrolled hypertension. And it's considered that the prevalence between the genders is very similar. So for our project, for our case-finding tool, we looked at data from Bedfordshire and Luton and Milton Keynes ICB, referred to as BLMK ICB. And on their population, they have nearly 14% of their population that are diagnosed with hypertension. And to get the diagnostic code, we use the ONS code for diagnostic hypertension diagnosis. And the diagnosis for hypertension patient is increasing every year, which is why one of the clinicians has highlighted that part of the beauty of a potential dashboard is that it will enable them to risk stratify patient and use the data to target the more vulnerable community, which is not possible at the moment with the current system. So they're hoping to be able to use the case-finding tool to highlight the uncontrolled hypertension patient within the population. So you see in this map, we've highlighted the BLMK area and divided it by LSOS, where you see where we highlighted the deprivation decile per LSOS. So the deprivation decile is 1 in red for the most deprived area and 10 for the least deprived area. And you can see on the map, you have some area, for example, in Milton Keynes and Luton, where you have pockets of hypertension. And then in this map, not only have we highlighted the deprived area, but we've also added the hypertension patient count. So each dot is there's one dot for each LSOA, and the darker the red in the dot, the more patient there is with hypertension within the LSOA area. And if we look at Milton Keynes in particular, you can see, so on this side where you've got Milton Keynes, you can see some of the dark area, so high deprivation zone have also high count of hypertension, whereas in other areas that have less deprivation, you have less patient with hypertension. But you can also see at the top over there in blue, you've got an area that has less deprivation, but that does have quite a high count of patient with hypertension. And if you compare it to the other side where we've got Bedford, where you have some area with less deprivation, but that also has less patient that have hypertension. So now, why do we need a hypertension case-finding tool? So NHS England, Public Health England has stated that disease caused by hypertension costs the NHS £2.1 billion every year. And the negative effect of uncontrolled hypertension are higher risk of heart attack, of stroke, but also higher risk of peripheral artery disease. And you can see in the graph in there that disease caused by hypertension, like coronary heart disease, cost the NHS £750 million a year, while stroke, for example, cost the NHS £850 million a year. So we can see that hypertension costs the NHS quite a lot of money every year. Now, looking at hypertension at a national focus, we can say that Core 20 plus 5, one of the part of it is to look at hypertension. And as some of you may know, Core 20 plus 5 is a national NHS England approach to inform action to reduce health inequality at both the national and the system level. And as the name indicates, Core 20 refers to the 20% most deprived area, population in the UK, and the plus 5 refers to 5 areas of focus. And those 5 areas of focus are maternity, early cancer diagnosis, severe mental illness, chronic respiratory disease, and hypertension case finding, which is what we're talking about today. And as part of Arden GEM CSU, we have worked on 3 of those areas. We've worked on the dashboard for severe mental illnesses to predict various mental health conditions. We've also worked on a respiratory disease dashboard for COPD, so chronic obstructive pulmonary disease, where we've added a machine learning and a case finding tool to that, where in the machine learning we're predicting emergency readmission. And now we are trying to do something similar with the hypertension case finding. And the dashboard itself would be used by both clinicians, and it will be used at the ICB level for benchmarking. And from the beginning of that work, we've had clinical input to help us inform the dashboard as well. So now, looking at the actual dashboard page, the first page that they will get is a summary page that you can see behind me here, where it will provide them with an overview of their population using aggregated data. And in that, we're separating the patient in 3 different risk groups that are hypertension patients that have been diagnosed with hypertensive heart renal disease, and patients that have intracranial hypertension. And those 3 different groups are then subdivided into 3 different graphics, where they'll be able to look at their patient demographic by age group, then their ethnicity spread, as well as deprivation decile for patients with those long-term conditions. And the clinician will then be able to create their own patient groups and look at specific groups using different demographic filters, which will allow them to look at specific patient group that they want to concentrate on. And now I'm going to be handing over to my colleague Anne to look at the machine learning side as well as the case finding tool of the dashboard.
Thank you so much, Farah. It's awfully loud. So going on to the next slide. So what we see here is actually the cohort of patients that you would actually see. So this is all of the hypertension patients that you would see. And what we do here is you can see that they're filtered by demographics, age group, gender, key characteristics, health status, LTCs, which you may be familiar with, stands for long-term conditions. Might be a bit small for you to see for those at the back, but you should have screens on the side. We'll come back to the machine learning risk score as well, because that's the product that we're really selling here as well. In terms of IP admissions, we also present that, how likely they are to present, and also they're within 6 months. QRisk is actually something that is derived independently. So you may know about QRisk 2 score, which is the likelihood of them developing a cardiovascular disease event. And LTCs also are there. There's also, importantly, the uncontrolled hypertension outcome. So whether they actually fit into the group that Farah has already described as having hypertension or not. So this is a binary, 1 or a 0. And of course, the clinicians would also like to see diastolic BP and systolic BP. So what you see here is actually what the clinician would actually see. So this is at a kind of higher level overview. So furthermore, you can actually, the clinician can actually look at this and filter. So just above my head, if you can see well, you can see there are different filter options. There's gender, ethnicity, the things which are essentially that I've mentioned, and you can put them within different ranges so that if you think from a clinician's perspective, if they were to look at all of these patients, what would they know what to do next? They wouldn't know what to do next exactly because there's far too much information. So if the clinician in BLMK, they would be mindful perhaps of their own, the specific nature of their population, then they can actually hone down perhaps to look at, the more aging population and, bring the cohort down to a smaller size so that they can begin to develop a more bespoke care plan and think about who they might actually bring in next week, essentially, or even this week. So drilling down just a bit more, you can actually see patient-level details here. So just for obviously confidentially, patient identifier information is not shared here. But what we can see here is the patient journey critically. So in primary care, you can see the number of GP appointments that they've had. So in this instance, it's 119. And from there, they've also had 14 inpatient admissions. So this is just a description of one patient. And next, we'll actually pinpoint where they actually had this heart disease event. So it was in the middle of this time course, and for reasons we can't share exactly the timeline because you can actually identify this patient otherwise. They actually had an event related to heart disease, and that was categorized as such in the middle of this timeline. With that, the doctor can actually see what has been their kind of CVD status going across that particular timeline. So it's not just they're being overwhelmed with, they might, patients these days, they can have many conditions. And we're interested here in hypertension. And so with this outlook in mind, this would actually help the doctor to understand where was the last event they had, what has been the frequency of the events that they've had related to heart disease has been. Is it clicking okay? Brilliant. Okay, so just moving on to slightly more technical things, but important things. First of all, we don't do anything without first speaking to the client. So we actually spoke to 2 GPs from the ICB, and they were very helpful in helping us to understand what their needs were. So we actually designed the dashboard with them in mind, and then we were able to extract the relevant features that we thought that they would be interested in, and then we moved on to model development, and we're still at this point because we're at phase 1, just so you know, and ultimately it will be deployed through our own Athena system, which is a way of deploying dashboards in a unitary fashion, and ultimately business decisions, clinical decisions will be supported from the dashboard that we have created. And these are things that we have developed last year, if you were also here for talks around COPD and diabetes as well. So just moving on to the machine learning part. So it's created around a linked data set. So what that means is that it's all linked together by one field. So the field here is the pseudo-anonymized number, and it's all brought together, and that is ingested into the dashboard. And the ML score itself, which I'll go into shortly as well, is actually trying to predict the likelihood that someone who has hypertension already will develop uncontrolled hypertension. So just to be clear, what we're trying to do with the ML score is give a likelihood of a person who already has hypertension is going to then develop uncontrolled hypertension. And in terms of the predictive components, we are thinking of using logistic regression and XGBoost. Logistic regression mainly because it's the first thing you think about. If you think about binary classification, it's simple, it's easy to explain, and if it works really well. XGBoost we choose because it's customizable, though it is a decision tree based ensemble type learning procedure. It can actually be quite customizable and yeah, essentially logistic regression is just a nice way of saying whether they are yes or no in a simple fashion, and XGBoost is a slightly more advanced way which can be tweaked according to the requirement and is based on improving the errors as you go through the stepwise process of modeling as well. In terms of feature engineering, so in terms of choosing the features that would go into this model, what we did was we removed stepwise. So we started with the entire feature space, and then over time we used a process called reverse feature elimination, which essentially removed piecemeal, like stepwise, one feature at a time, to find out how explanatory were the remaining features of the actual the score. And in terms of data imbalance as well, we use SMOT, which my colleague Camille explained really well yesterday if you weren't there, but it's essentially a way of addressing the oversampling, because naturally you will have a low number of uncontrolled hypertension cases compared to the whole population of those who have hypertension as well. So now we arrive at the final slide. So what we have really planned in mind is that we will present this case selector much like we've done in the previous works that we've done, with these key characteristics: age, gender, ethnicity, deprivation, and the key clinical measures that relate to hypertension. And it is something that we believe, and also with the clinicians' input, will actually help them to make better decisions to actually curb the tide of uncontrolled hypertension, so that they can see ahead of the curve and respond in a more appropriate manner. So yes, I mean, the costs saved would be, I would say, tangible, but we really have to develop studies to really understand a bit further what that entails. But I think the idea around public health is that we try and prevent and not treat if we can. And furthermore, we also have further dashboards which we have in mind as well around chronic kidney disease, atrial fibrillation, and others. But thank you so much for listening, everyone, and we look forward to receiving your questions as well.
That's great, thank you, Anne. Farah?
Yeah, we got quite a few questions from this talk, so I'm going to try and pick through them in a half sensible order, just to try and group a couple that seem similar. But yeah, first of all, how does this tool differ or overlap with CVD Prevent?
I'm not too aware of CVD Prevent, if anyone could perhaps inform me.
Perhaps the person who asked that question could catch up you.
Yeah, I think we can definitely catch up offline, so we can share our email addresses as well.
Yeah. Awesome, yeah.
So that tool, the case finding tool, it was created with clinicians in mind, in that we had a couple of clinicians that were very involved with it, and they also gave us some specific codes for clinical events that they want to be able to see in the dashboard. So I'm not sure if they used that other tool, but that was very clinical clinicians involved, so they really want that tool.
That kind of leads nicely into next two questions. So how have you managed to get clinicians to actually use the dashboard? And then kind of what is the specific purpose of the dashboard? What interventions can be put in place as a consequence?
So the procedure that we normally have is we've got clinical input from the ICB at the beginning. where we create, and then we create a dashboard. And then once we have created a dashboard, we will publish it into our application called Athena. And within Athena, the clinician have access to it. And the way Athena is created is all the various dashboards have a very similar look in terms of navigation. So if they've used one of our dashboard in Athena, they can use any other dashboard in Athena in a very easy way to use. And once we've got the dashboard in Athena, we've got user testing done from the clinician. So we may have other meetings with them where they'll give us some feedback. And one of the feedback we get most of the time is to change the case finding tool itself a little bit. So changing the different feature that we put in, whichever clinical measure that we've put in. Sometimes they've asked us to add stuff to it most of the time. So we try to add what they've asked us, and hopefully we're able to create a tool that they can use because they've informed us of what they wanted to see within the tool.
Excellent. So next question is, you mentioned Q-risk score. Which version do you use?
It said Q-risk 2.
Q-risk 2, brilliant.
I don't know if it was clear in the slide.
So how did you get IG agreements surfaced to hospital patient identifiable data to GPs?
Can you repeat the question?
Yeah, how did you get the IG agreement to surface that hospital and patient information to the GPs?
I think we have an agreement with BLMK that we're doing work.
Yeah, so within our tool, Athena, normally what they see, they don't see the patient NHS number, for example, but within Athena, there's an option, depending on the role that the clinicians have, they're able to re-identify the patient within the Athena tool. Obviously, we don't have access to that, but there's something in the system that allows clinicians to re-identify the patient list, and it also links back to their system as well, so they're able to, from the page, from the case finding page, they're able to go back to their own system to have a look at the patient details in more details.
Great.
So we do that at GP levels for BLMK, but for some other project that we've worked on, we've also done it at PCN level, for example, for a diabetes dashboard that we have with BLMK. So it depends on the access that the users have. So they either have PCN level access or GP access, and they're able to identify only to the access that they have.
Right. So I really like this next question. So you've defined the your hypertension is with certain limits, isn't it? 90 and was it 140? Is there any way for a clinician to say this patient isn't above those limits, but I believe that clinically this is presenting as hypertension, so they want to add them to the list?
So at the moment, our cohort list only has patients that have been diagnosed with hypertension, because that was the ask from the clinician. They wanted to look at patients that already have hypertension and then concentrating on those patients to find the one that have uncontrolled hypertension.
Okay.
So at the moment, we don't have patients that don't yet have hypertension, but that's a possibility to add, but that wasn't the ask of the dashboard.
I think with that, we'll have to discuss with the client a bit more about the characteristics around pre-hypertensive patients, what they would look like, so that we can include that as criteria. Because, yeah, otherwise we wouldn't be able to do that. That makes sense.
Still got time for a couple more questions, I think. So has the process revealed any issues regarding missing data or data quality? And if so, how has this been addressed?
Yeah, it's still a work in progress.
Still a work in progress, yeah. I think that's one of those, it's hard to know about unknowns, isn't it? Do you know why the diagnosis rate for the Bedfordshire ICB is so much lower than the country average? Because I think you said the country average was about 20%, was it? And it was 14% for Bedfordshire.
The reason for that?
Yeah.
I think speaking to the clinicians, they didn't tell us particularly where they sat, so they didn't give us a comparator. We really asked them how we were focusing on their area. I imagine, it's just speculation, but in terms of data capture, I don't know whether it's a complete capture, but we would hope and assume that we'd have all the patients that were relevant. We hope that also the codes that we used actually were capturing all of the hypertensive patients as well. But it's something that we can also think about, yeah, knowing that it's 6% below as well. So obviously they're doing something well, but if you know what I mean. So yeah, maybe we can take that back to the client and ask them, is this reasonable? What do you think about this as well?
Quickly, I guess we've got time for one more. So do you plan to integrate your multiple dashboards?
Sorry, integrate?
Yeah.
It would be possible, but they would have to have individual models, data models underlying them. It is possible. It would just, the only limitation is when the clinician is using it, we'd have to almost redub the dashboard. It wouldn't be a hypertensive, obviously it wouldn't be a uncontrolled hypertension early detection dashboard anymore. It would be something else, like a dual, triple condition, but then it becomes a multiple long-term condition dashboard very quickly. And what is navigable, information flow, I think the dashboard may have to change, and we'd have to think about a new kind of layout to accommodate for that. But that's definitely something that would be the future, I think.
Great. I think we'll have to call it there for time purposes. So again, once again, thanks to Farah and Fran for that presentation.